Hello, my name is Marie, and we are going to be reviewing. Next, let's talk about terms to know when you are charting. This is a picture of what the flow sheet from your head to toe assessment looks like. If you look over on the right-hand side, you will see that it defines the within defined limits definition. This is how you know if you can chart within defined limits. Let's see what this looks like. So you can see here, you're going to go to your box. And when you review over on the right-hand side, what we're circling here, this is your within defined limits definition. If your patient meets that criteria, you can chart within defined limits. If they do not meet that criteria, you only chart what does not fall within the defined limits. Let's review the charting requirements for your clinical area. You should have a handout to review your unit's RN charting expectations. Generally, on your acute care units, BMT and hematology, Huntsman 5 and Huntsman 4, you are expected to complete one full head-to-toe assessment each shift, and you should chart as you do it. If your patient condition changes, you should repeat a full head-to-toe assessment or maybe a focused assessment depending on your patient's condition. In the ICU, you will complete a full head-to-toe assessment every 4 hours. And then you will also repeat this as your patient condition changes. Next, we are going to review how to chart a head-to-toe assessment. In this part of the presentation, we will review findings of a patient assessment, and I will show you how to chart it in Epic. Let's start with the neurological assessment. Your assessment findings, your patient can open their eyes, they are oriented to their verbal response, and they obey commands. Your patient is alert and oriented to person, place, time, and situation. Pupils are equal, round, and reactive. Speech is clear and appropriate. The patient obeys commands, has normal strength and sensation in all 4 extremities. Let's review over on the right your WDL definition. Compare your assessment findings to the WDL. Does this patient meet the WDL definition? This is what your charting should reflect for this assessment finding. You will chart your Glasgow Coma Scale, the eye-opening, verbal response, and motor response. This patient met the WDL definition. So all we will chart for this patient is WDL. Next, let's review the ear, nose, and throat section, or the EENT section. This is what we found on our assessment. Your patient's eyes are clear with no discharge. Your patient is wearing glasses. They do have some white spots in their mouth. Their teeth are intact. The patient complains of sore throat upon swallowing. They have a normal voice, and there are no foreign bodies in the mouth. Go to the right-hand side and let's look at the WDL definition. Does this patient meet the WDL definition? Let's review how we would chart this section. First, this patient does not meet the WDL definition, so you will do an X. And remember, you will only chart the exceptions. So this patient wears glasses. So we're going to include this in the comment because there's nowhere else to chart that the patient wears glasses. This patient had white patches in their mouth, so we're going to go to mucous membranes and chart it there. And the patient had difficulty swallowing, so we will chart difficulty swallowing on the throat. As you can see in this charting, all we did was chart what was not within the defined limits. We don't have to chart everything that is normal. We only chart the things that are not within the defined limits definition. Next, let's review the cardiovascular section. Your patient's assessment findings, their heart rhythm is regular with S1 and S2. They have palpable and regular dorsalis and radial pulses, and they have a cap refill of less than 1 second. Does this patient meet the within defined limits definition? Yes, this patient is within defined limits. As you can see, we only need to chart WDL because the patient met the definition of the WDL. Next, let's go to the peripheral vascular system. Our assessment findings are our patient has 1+ edema on the lower extremities bilaterally. If you look over at the WDL definition, we've already assessed these in our previous findings. The patient had a capillary refill of 1 second and the pulses were palpable, and that we charted in our cardiovascular section. So, comparing the definition to our assessment findings, does this patient meet the WDL definition? The patient does not. So we are going to chart X because they are an exception to WDL, and we are going to chart the edema that we found. So you'll select edema, select the right lower extremity and left lower extremity. After this, you can press return, and then it will bring up the options for charting the edema. So we have the right, we're going to select 1, and the left, we're going to select 1. And that's all we're going to chart for our peripheral vascular because everything else is within defined limits. Next section on the head-to-toe assessment is pulses. This section is only used if your doctor orders more frequent pulse checks. For example, if your patient is ordered to have radial pulse checks every 4 hours, you would chart it here. Because this falls within our cardiovascular and peripheral vascular systems, we don't need to chart it here as well. Next on the head-to-toe assessment is the neurovascular assessment. This assessment is a repeat section for the most part. We go over capillary refill, color, temperature, which is something we have already addressed in previous sections. This section is great for charting peripheral neuropathies in our patients. If in your neurological assessment you find that your patient has neuropathies, this is a good section to chart under paresthesia. You can chart a full thorough assessment on the neuropathies. If the patient does not have neuropathies, you do not need to chart in this section because the previous sections have already been charted. You can also use this section if you want to do a more in-depth assessment on capillary refill, color, temperature. Next is the respiratory section. So this patient, in their assessment findings, we found that their breath sounds were clear in all lobes except for the right lower lobe, which was diminished. Respirations are unlabored and chest excursion is symmetrical. The patient has no complaints of shortness of breath or difficulty breathing. Let's review the WDL definition. Does this assessment meet the WDL definition? This patient does not meet the WDL definition. Let's look how to chart this. So you would chart an X for exceptions to WDL. What was the exception? The right lower lobe was diminished. So we will go down and find the right lower lobe, select diminished, and our charting is complete because that is the only thing that was outside of the WDL definition. Next is the gastrointestinal section. Our assessment findings were our patient's last bowel movement was in the morning. Patient's bowel sounds are present and normal. Patient is complaining of nausea this morning, and their abdomen is soft and non-tender. Now, in this WDL definition, it only includes for the emergency department if the patient does not present with nausea, vomiting, or diarrhea. However, with the purposes of our oncology population, if your patient is presenting with nausea, vomiting, diarrhea, chart that as an exception to WDL. With that in mind, does this patient meet the WDL definition? This patient does not meet the WDL definition. This patient complained of nausea. So you would go down to the GI symptoms and select nausea. This is also where you will find diarrhea and constipation. Next, let's review our genitourinary section. Our assessment findings was the patient is urinating clear and yellow urine, and they do not have any complaints of discharge from their genitalia. With that in mind and reviewing our WDL definition, does the patient meet the WDL? They do. So this would be how you would chart. There is an option for a genitalia assessment within the head to toe. If you complete a full genitalia assessment, you would chart your findings here. Next, let's review the musculoskeletal section. Our assessment findings were all 4 extremities have full range of motion, the patient has no deformities, and the patient has bilateral SCDs in use. With this in mind, does the patient meet the WDL definition? This patient does. This is also a place where you can chart if the patient is using SCDs. Next is the integumentary or skin section. Our assessment findings were the skin is intact, warm, and dry, and the patient is pale. Let's review the WDL definition real quickly. Here it also has mucous membranes. We previously charted this on the EENT section. The EENT section offers a more thorough assessment. What we recommend for charting mucous membranes is being consistent on where you chart. So if you choose to chart the mucous membrane abnormalities in the integumentary section, be consistent with all of your patients. Going back to the WDL definition, does this patient meet the WDL definition? The patient does not. So if you go to exceptions to WDL, the patient was pale, so we're going to select pale. Next is the psychosocial section. The assessment findings were the patient is calm and cooperative, and the patient is acting appropriate for their age and situation. Does this patient meet the WDL definition for the psychosocial section? Yes, this patient meets the WDL definition for psychosocial. Next, we'll review the Morse fall risk. This is required to be charted at least once a shift, or if there is a change in patient risk. First, you need to chart if the patient is a seizure patient. Do they have a history of falling? Is there a secondary diagnosis? Is the patient using an ambulatory aid? Looking at the patient's gait, IV therapy or IV access, and mental status. You will find a full definition of each of these sections in your handouts. So as you can see, this patient's Morse fall score risk is 35. Next is the Braden scale. This also needs to be charted at least once a shift or as your patient risk changes. So the patient does not have any sensory impairments, so this patient will get a score of 4. Their skin is rarely moist and they're only requiring 1 linen change a day. This patient walks occasionally during the day. However, they do spend most of their time inside the room. This patient is able to make major and frequent changes to their position. This patient eats all of their meals provided and does not require any supplementation. This patient also moves in the bed and chair independently and has the strength to move and maintain good position. You will find the definition of the scores in your handouts so you can understand how to score these. This patient's Braden scale score is a 22. Next, we're going to go over how you chart your rounding. A couple important things to remember when you are charting your rounding. Chart only what you assess. Let me show you a couple places where you can chart your rounding. Let's start on the head to toe flow sheet. You can chart your Glasgow Coma scale. You have eye-opening, verbal response, and motor response. However, remember, if your patient is sleeping, we can't always assess that. So make sure you only chart what you assess. Another example is your patient nauseous. Maybe you asked your patient if they were nauseous. You would go down here to GI symptoms, and I would only chart nausea. Remember, I'm not going to chart anything WDL or exceptions because I am not doing a full assessment. So I would only chart nausea and nothing else. Next, let's go to the daily cares and safety. Activity is a great section. There's also hygiene, nutrition, incentive spirometer. You can go to pain assessment and chart a pain assessment that you complete. Or there's a one-stop shop in purposeful rounding. Here you can chart primary pain, you can chart any output, activity, or safety, or if the patient goes off the unit. Again, chart only what you assess and make sure to give yourself credit for the hard work you do. Chart every time you go into the room so that way we know that you are doing what you need to do to take care of your patients. Next, let's review lines, wounds, and drains. All lines, wounds, and drains need to be charted on every 4 hours. Let's review intravenous access. Any line should have at least 3 areas charted with every assessment every 4 hours. The site assessment, the lumen status, and dressing status. Remember, only chart what you assess. And remember to chart all your dressing changes, tubing changes, and cap changes with a date. Here's an example of what your WDL definitions are for your different statuses. This is an example of a port. If you look at the site definition, the WDL is there is no blanching, no bleeding, crepitus, drainage, or leakage. It is not painful. Neck veins are not distended. It's cool to the touch. No redness, swelling, or bruising. Let's review the lumen status. The WDL definition for lumen is it aspirates and flushes easily. There's no leaking, and it's cleaned per hospital policy. There's also brisk blood return. So when you flush any kind of IV, you can chart it here that it flushes easily. Next would be the dressing status. When you're charting WDL on the dressing, you are saying the dressing is clean, dry, and intact. Next, let's review a wound. Your assessment and charting should include anything that you assess. This can include appearance, site, drainage, and the dressing type, and what you do with the dressing. Measurements should be charted weekly, and an image should be taken on admission and if there are any changes to the wound. Remember, this needs to be completed every 4 hours. Next is drains. Again, this needs to be completed every 4 hours. The assessment and charting should include site, any dressing, activity or type, drainage. Did you do any interventions to the drain? Are there any connections on the drain? Did you flush your drain? And is there any output? Next, we are going to review the clinical course. First, let's review the summary of clinical course. The purpose of this is to see the full clinical course of your patient. Think big events. You can see examples of here. We have close supervision. Did the patient die? Did the patient have a procedure? Was the patient transferred to the ICU or transferred back down to an acute care unit? Did the patient require a one-to-one? Was there any suicide attempts? Did you have to start end-of-life care? Were restraints started? These are your options you can see here. One thing that's important that you will do daily here is your 24-hour chart check is charted here. And think big events. If you call a rapid response, if you call a code, that's where this is charted. And also remember when you're charting here, does this need to be an RL6? Next is a fall. If your patient falls while you are caring for them, this is where it should be charted. And remember to also fill out an RL6. Next, let's review bedside procedures. This is where we charge for additional nursing time that it takes to complete these bedside procedures. Remember, we should only charge if the RN is completing or assisting with these procedures. I highlighted a couple examples that you might use frequently. First is bladder irrigation, intermittent. So if your patient has a clogged Foley and your doctor orders to flush the Foley, this would be an intermittent bladder irrigation. Next, a bone marrow biopsy. If the RN assists with the procedure, then you would charge for a bone marrow biopsy. If a tech comes up and does all of the work for the bone marrow biopsy, we would not charge for that because it is not the RN that is completing or assisting the procedure. Next is a fluid resuscitation. We can charge for a fluid resuscitation if we are administering more than 2 liters of fluid within a 24-hour period. That is a bolus. So if your patient is getting 2 liters of fluid with a maintenance IV, we would not charge for a fluid resuscitation. This would be if the doctor orders a bolus of fluid to be given. And again, it is 2 liters of fluid. If you have any questions on whether a bedside procedure can be charged for, your CNC on your units is a great resource to ask these questions to. Next is a critical value. If the lab calls you with a critical value, you will chart it here. You can see we have cardiology, lab, pulmonary, radiology. And you can see you would type what the critical result is and the provider that you provided the information to. Next is acute change. This is where we will chart calling the provider. If you look under patient acute change, you can see the second option we have called provider. If you are calling the provider about anything and want to document it, this will be where you will chart it. Next is a medication adverse event. This is where you would document an adverse event to any medication you might administer. Remember that when you chart this, we should never refer to an RL6 in our EPIC documentation. If you have any type of medication adverse event, infusion, oral, no matter what it is, we should always fill out an RL6. In an infusion adverse event, this is where we would chart any hypersensitivity reactions to any infusion or any extravasation or site injuries. Let me show you what this looks like. You can see on the top we have adverse effusion events. So we are going to select a new reading. The document injection site reactions is for any extravasation injury or any site injuries. The infusion reaction is for any hypersensitivity anaphylaxis reactions. First, let's start with the injection. You can see, make sure we chart that we notified the provider. Is the patient having irritation or extravasation? What the drug was, if we administered any treatments, and any additional documentation. Next, let's review an infusion reaction, and this is with any infusion. It can be antibiotics, it can be chemotherapy or immunotherapy. We're going to chart if we notified the provider. Now, if you look on these infusion reactions, if you hover over the boxes, you are going to get the definition. So you don't need to remember these, but this is where you would find that information. You hover over and the grade definition will come up. You can see you'll do the agent, if you administered any treatments. Did you restart the infusion? Did you complete the infusion? Then we go over kind of a new system assessment. Skin reactions. Again, you can see there's a grade 1, 2, and 3. If you hover over these boxes, you will get a definition. You'll have cardiovascular reactions. You can see here how we hover over and we can get those definitions that we need. Any general reactions, we have gastrointestinal, respiratory, eye, ear, and neurological reactions. After you're done completing the charting, you'll review your charting, make sure you completed all the different sections. Then you can go down to the bottom and select Close. If you would like to review this within a flow sheet, you can select in the upper right-hand corner flow sheet, and you can chart the exact same information within a flow sheet. And this is an example of how the information comes up. If you go down to one of the reactions, so this is a skin reaction, and then we're going to go to pruritus. You can see it has the grade 1, 2, and 3, and you can hover over for the big definition of what those mean. So those are two different options in how you can chart the adverse effusion events. That concludes our presentation on how to document a head-to-toe assessment, lines, wounds, and drains, and the clinical course. Should you have any further questions about documentation, please reach out to your area's nursing professional development practitioner.